Good evening, colleagues. Thank you, everyone. My name is Jana Martin, and I'm the Senate Joint Chair of this committee. And I'm joined by the Honourable Marc Garneau, the House of Commons Joint Chair. Before we begin, we have a vacancy in the Vice Chair position, and the clerk will now preside over the election of a new Vice Chair. Clerk?
Pursuant to Standing Order 106.2, the first Vice Chair must be a member of the official opposition. I am now prepared to receive motions for the first Vice Chair. Madame Vian.
Oui, merci. Bonsoir à chacun.
Thank you. I would like to nominate Michael Cooper, please.
It has been moved by Madame Vian that Mr. Cooper be elected as first Vice Chair of the committee. Are there any further motions? It has been moved by Madame Vian that Mr. Cooper be elected as first Vice Chair of the committee. Is it the pleasure of the committee to adopt the motion?
Okay, congratulations. Today we are continuing our examination of the statutory review of the provisions of the Criminal Code relating to medical assistance in dying and their application. I'd like to remind members and witnesses
that's great. Thank you so much.
To keep their microphones muted unless recognized by name by one of the joint chairs. A reminder that all comments should be addressed through the joint chairs. When speaking, please speak slowly and clearly. Interpretation in this video conference will work like an in-person committee meeting, and you have the choice at the bottom of your screen of either Floor, English, or French. With that, I'll welcome our witnesses for this evening's first panel. And first of all, representing the Canadian Society of Palliative Care Physicians is Dr. Romain Gallagher, Clinical Professor, Palliative Medicine, University of British Columbia by video conference. And from the Canadian Cancer Society, Kelly Massotti, Vice President Advocacy by video conference, and Daniel Nowosielski, Advocacy Manager, Hospice Palliative Care, also by video conference. And lastly, we have on behalf of the Dorothy Lee Hospice, Donna Cansfield, Chair of the Board of Directors by video conference, and Dipti Purbu, Executive Director, also by video conference. Thank you all for joining us this evening, taking the time to help us in this important study. We're very tight for time this evening, so we're going to be quite strict with our timing. We'll try and give you a 1-minute warning, and please keep your remarks to 5 minutes. We'll be beginning with Dr. Gallagher, followed by Ms. Massotti and Ms. Purvu. So Dr. Gallagher, you have 5 minutes.
Thank you, Madam Chair. Thank you for allowing me to speak on behalf of the Canadian Society of Palliative Care Physicians. I'm here to clarify previous testimony about the state of palliative care in Canada. There has been a struggle to define palliative care. The World Health Organization defines palliative care as an approach that improves the quality of life of patients and families who are facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment and treatment of pain and physical, psychosocial, or spiritual problems. Addressing suffering involves taking care of issues beyond physical symptoms. It offers a support system to help patients live as actively as possible until death. Palliative care is explicitly recognized under the human right to health. We should provide palliative care in response to needs, not according to prognosis and not just in the last weeks of life. Health Canada reports on MAID fail to indicate quality or quantity of palliative care received, but they show palliative care is often provided late in the illness, with 21% receiving it in the last 2 weeks and 18% less than 4 weeks prior to MAID. Research shows that late involvement in palliative care leads to suboptimal pain and symptom management, increased suffering, failure to discuss and adhere to advanced care planning, and unplanned hospital deaths. An Ontario study of people dying of cancer who received palliative care for greater than 6 months before death compared with those who had less showed a lower chance of needing hospital care and dying in hospital and an increased chance of receiving care at home in the last month of life. CIHI data and other Canadian studies reveal that those who do not have cancer receive less palliative care and later in their illness. Palliative care needs national standards for palliative care provision across healthcare sectors, embedded in accreditation processes that organizations must pass to receive healthcare funding. We must develop indicators that are proxy measures for quality of life and not just place of death and when palliative care was accessed. We also need patient-related outcomes where we track symptoms and distress during serious illness. This will take some dedicated funding for several years to achieve, but then we would have accurate data to assess our care of those who have life-limiting illnesses. Some state that most people seeking aid do so because of existential suffering. This argument attempts to neutralize the potential influence of palliative care in mitigating suffering, and it reassures lawmakers that MAID is the only option for existential suffering and there's no need to improve palliative care provision. Yet Health Canada reports existential suffering at 3%. It appears that MAID proponents characterize loss of ability to engage in meaningful activities, listed as 86% of MAID patients, as existential suffering. If this all seems confusing, that is because it is nearly impossible to separate one kind of suffering from another. Like a coin sorting machine, we cannot dump a bag of suffering in at the top of the machine and have it sort out into different denominations such as physical, psychological, social, existential, etc. It is important that you understand that the division between these different sources of suffering are artificial, as all these spheres are connected. For example, think of a person living with inadequately managed pain, which has limited her mobility, heightened her dependency on her partner, causing her to feel a burden and undermined her sense of agency and sense of self.
1 minute.
This is typical of the nature of existential distress seen in patients with life-limiting conditions. Controlling her pain gives her back her mobility and independence, and other practical and emotional support returns her sense of agency and reduces the feeling of being a burden. In other words, providing quality palliative care is very effective in alleviating existential distress, as are some psychological interventions specifically designed for patients with persistent suffering. There are decades of research and clinical practice behind this. Palliative care is optimally delivered in teams because it takes a team to meet all the needs of a patient and their family. Team-based care has strong evidence showing improvement in symptoms and quality of life, less caregiver distress, reduction in ICU and hospital stays, and reduced healthcare costs. Canadians will suffer with life-limiting illnesses whether they access MAID or die naturally. They are counting on you to ensure quality, timely palliative care to all Canadians.
Thank you very much, Dr. Gallagher. Next, we'll have Ms. Masadi for 5 minutes.
Good evening. Thank you, Chair and committee members, for having us here today. My name is Kelly Masadi, and I'm Vice President of Advocacy. And with me today is Daniel Nowosielski, Advocacy Manager, Hospice Palliative Care. Before I begin my remarks, I would like to acknowledge that I am speaking to you today from the traditional unceded territory of the Anishinaabe Algonquin people. The Canadian Cancer Society is committed to supporting people with cancer and their caregivers by ensuring they have the information they need to make decisions about palliative care, advanced care planning, and end-of-life care, including medical assistance in dying. Since 2020, our helpline has responded to more than 300 inquiries specifically about palliative care, more than 200 about grief and bereavement, and 40 related to medical assistance in dying. Everyone with a life-limiting illness deserves care that provides comfort, dignity, and choice. Palliative care isn't just for those in the last days or weeks of life. It doesn't mean death will come faster or that anyone has given up. In fact, research shows palliative care can help people live longer by focusing on care that helps maintain quality of life, relieve symptoms, and provide support in the setting of their choice. For some, palliative care lets them step out of the role of caregiver and allows them to simply be a daughter, husband, sister, or loved one. For others, it can be comforting to know their loved one is getting care to help reduce pain and minimize symptoms. For many, palliative care helps guide patients and their loved ones through the stages of life and grief that accompanies it. Critically ill patients are falling through the cracks when it comes to palliative care. According to CIHI, while people with cancer generally had greater access to palliative care than those with other chronic or life-limiting illnesses, the data says we still need to get better. Among patients who died in hospital with a cancer diagnosis, only 41% were hospitalized primarily for palliative care, and 3 in 4 had no indication of palliative care needs prior to their final hospitalization. Access to palliative care differs by geography and population. Even when palliative care services are available, not all Canadians know about these services or how to access them. Those who are informed about palliative care often find out about it too late. Finally, those who access palliative care tend not to receive it in the setting of their choice. At the same time, at the end of life, many decisions need to be made taking into account an individual and their loved one's values and preferences. According to Statistics Canada, while cancer is responsible for the death of more than 1 in 4 Canadians, it represents 67.5% of the underlying medical conditions of all reported MAID requests. CCS respects and supports all Canadians with cancer by helping them make informed choices and autonomous decisions about their care. These choices include MAID. I will now turn my remarks over to Daniel.
Thank you, Kelly.
2 minutes remaining.
Thank you. I'm speaking to you from the traditional and unceded territory of the Kanekahaka or Mohawk, a place that has long served as a site of meeting and exchange amongst many nations. Palliative care not only benefits the people who receive it and their loved ones, but at a time when we are facing significant challenges in our healthcare systems across the country, CCS believes investing in palliative care would help to relieve the pressures faced in other parts of our system and improve overall performance. But the current specialized palliative care workforce is not large enough. We do not have sufficient beds in hospice and community to meet the growing demand and changing needs. We recommend the federal, provincial, and territorial governments continue to prioritize palliative care in their bilateral funding agreements on healthcare to expand access to palliative care services and hospice beds. This includes increasing the availability of specialist resources for consultative advice and education, orientation, and training for all care providers in providing a palliative approach to care. Furthermore, we echo the recommendations made by the Quality End of Life Care Coalition of Canada in their pre-budget submission regarding investments into research into palliative care and investing in data and standards for palliative care. Regarding access to MAID, a written submission from May outlines several recommendations regarding consistent access, data collection, ongoing program evaluation, and education and training for healthcare providers. Ultimately, anyone with a life-limiting illness would benefit from greater and earlier access to palliative care from the point of diagnosis up until their death. But our healthcare systems do not have the capacity to consistently accommodate the choices someone with cancer and their loved ones would like to make regarding their goals of care, their setting of care, or what their final days might look like. Everyone in Canada should have access to affordable, culturally safe, high-quality palliative care, as well as the ability to make autonomous decisions about the care which will impact the quality and outcome of their life.
Thank
the federal
you.
government. Thank you.
Thank you very much. And lastly, Ms. Purbu for 5 minutes. Or is Donna Cansfield speaking, perhaps? Ms. Purbu? Okay, Ms. Purbu, I understand you just joined our meeting. Thank you for joining us, and you will have 5 minutes. Hopefully, we'll see you soon. Will you please turn your camera on so we can see you on the screen?
Good morning, good evening. I'm so sorry. I'm trying to turn my camera on. We've been having some technical difficulties here, so I do apologize. I'm just trying to figure out how to turn my camera on. It doesn't seem to allow me today. Okay. No. I do apologize. I don't think my camera is going to turn on. And is that okay if I continue my talk without the camera?
I see nodding head. So yes, Ms. Prevost, you have 5 minutes.
Okay. So I do have Donna Cansfield here, who's our chair of the board of directors at the Dorothy Lay Hospice. So I'm going to ask her to start.
Sorry, Ms. Prevost. Sorry to interrupt. By chance, is your camera covered by something? No.
No, unfortunately, it generally works. It's been working all day. For some reason, it's no longer working.
Thank you. So we'll listen carefully then. Sorry. You may continue.
I do apologize.
Thank you, and thank you. I apologize as well with our technical difficulties. So good evening, and thank you for the opportunity to speak with you. This is very important to us. My name is Donna Cansfield, and I am the chair of the Dorothy Lay Hospice Board of Directors, and I have served both as a volunteer caregiver and a member of the board for over 30 years of involvement with the hospice. I support an individual's choice at end of life, but choice involves options, and one option is the support of end-of-life palliative care that's provided not only in the community, but also at a residential hospice. Palliative care must be available to all members of our diverse community, recognizing and respecting cultural differences, language restrictions, and the limited family support. Supporting an individual and their families is what we do. Care provided in the home with palliative physicians or at a hospice residence, respite support for caregivers provided by trained volunteers, day programs, ambulatory service care at a hospice, bereavement support for families. We navigate the complex health system for families who are frustrated with a system that rarely speaks to one another. We keep clients out of emergency departments and out of hospital beds. This is done through kindness, through caring, and our amazing staff. This is what we do. It's an extremely less expensive option, and it has been our experience that an option that's often chosen instead of made. However, we still support the decision of the individual, and we also provide that support if asked to do so. So if you helped us to believe in hospice palliative care, we could use your support, which would help others.
Thank you. And I would like to continue, and thank you again for the opportunity. My name is Dipti Prabhu, and I'm the Executive Director of the Dorothy Lay Hospice. I'm a nurse by background with over 25 years of experience in palliative and community care. Palliative care is an approach to care that focuses on what matters most to the individual. And through pain and symptom management, education, and support, the goal is to give the person as much time living with as much quality as possible. Palliative care also focuses on helping loved ones through the process with information and support. It is provided by a team of people, including doctors, nurses, social workers, volunteers, and family and friends. It is a powerful expression of compassion, kindness, and caring, and it is something that each and every person and their family should have at the end of life. It is what we would all want for ourselves and our loved ones. In Canada today, palliative care is not available to everyone. Access to palliative care is dependent on where you live, if there are hospice palliative care services available, how much information you have about palliative care, whether you speak the language, and whether your doctor or healthcare provider thinks that it will help you. As a result, many people do not get access to palliative care, which often results in death in hospital without support, and in some cases, people choosing medical assistance in dying. Medical assistance in dying is a choice that is available to those with a life-limiting illness. However, when people choose MAID because they do not have access to all palliative care options to help ease their suffering, MAID is no longer about choice, but about having no choice, having no other alternative but to suffer with no help. MAID should not be a substitute for all the options palliative care can provide. It is but one option, not the only option. In our experience here at the Dorothy Lay Hospice, we work with many, many patients at the end of life and their families.
1 minute remaining.
The reasons we have heard that people choose MAID is because they don't want to be a burden to their family. They don't want to suffer and die alone. They don't want to die in a hospital, and they're worried about getting care at home, or they want control over how they die. We have had many individuals. We have a current individual right now who has lived longer than her 2 months that she was given. And she wanted medical assistance in dying because she didn't want to be a burden to her family. With the support of our team, she's still thriving and hopes to come to the hospice to die when her time comes. We had another client who was in her late 50s, and she recently had MAID in her lovely garden after a family celebration because she did not want to see her children, to see her die. In closing, the right to medical assistance in dying is very important to allow for choice. Even more important is access to palliative care as a human right for everyone so that everyone can experience end of life pain-free and have as much time to spend with their loved ones. Access to palliative care will also ensure that those that do choose MAID are doing so because it is what they want, not because it is their only option to help with their pain and suffering. Thank you for your time today, and we do apologize for our technical difficulties and for you not seeing us in person. Thank you so much.
Thank you very much, and thank you for your testimonies. We're going to go into our first round of questions from the MPs, and we'll begin with Mr. Cooper with 5 minutes.
Thank you, Madam Chair. I will direct my questions to Dr. Gallagher. Dr. Gallagher, at a recent meeting of this committee, Dr. James Downer, in his testimony, stated that 98% of people who access MAID had received or had access to palliative care. By contrast, the data from the third annual Health Canada MAID report indicates that only 82% of those who had MAID did receive palliative care, and only 88% had access. So those numbers differ from those presented by Dr. Downer. As a representative of the Canadian Society of Palliative Care Physicians, can you shed any light on what the numbers are?
Yes, I have several things to say about that. First of all, there are no measures of the quality of palliative care, and really this is extremely important because people are very, as I mentioned, they have trouble defining it. So actually measuring the quality is also an issue. And really what we do know is that 20% had access to palliative care after they requested MAID. Now, when you think about it, this means that someone can be suffering pain, loss of independence, loss of meaning for, say, 2 years in the community, and they finally request MAID and they're admitted to a palliative care unit, they will be listed as having received palliative care. And it's important to keep that in mind. If you look at the people who did not receive palliative care, there is approximately 17%, I think, of those people. However, it said that it was accessible in 88% of the time. Now, what was it refused because the MD was not aware, or was it refused because the MD did not understand palliative care and it could be provided? So, for instance, I've had people with MS who appropriately needed symptom management and were told that they were not able to have palliative care. The thing is that if you even take the people who palliative care was not accessible in, so the 12% of the 1,474 people who didn't have MAID, that's 177 people who had no access. If advocates for MAID came to the government with evidence of 177 people not having access to MAID, I'm sure the media would pick it up and something would be done. But we are not seeing this kind of response to palliative care. needs of people. And I want to draw that to your attention, that it is not a minuscule number of people who lack palliative care.
Yeah.
The other thing.
Okay. Well, let me just say,
Okay.
I think are you citing Health Canada numbers and the numbers that you've relayed?
Yes, I am.
Okay. And we did have specific testimony saying 98% receive or have access to palliative care of those who do undergo MAID. Is that accurate?
Well, I actually listened into that talk by Dr. Downer, and I was confused as to whether he said 98 or 88% of those who didn't have access to palliative, or who did not have palliative care, had access to it. And I think there's huge problems with the federal public reporting. Because basically it's done by people who fill out a sort of a yes/no short order form, who often don't have extreme knowledge about palliative care. And this data is at best deeply flawed, and at worst, it's meaningless. And we are told that it's a critical component to support transparency and foster public trust in the application of the law, and I do not feel it meets that goal.
Any further data respecting access to palliative care beyond Health Canada data, or are you strictly relying on that?
No. There's actually an increasing number of studies on access to palliative care. And as some of my colleagues have said in this hour, it depends on your postal code. It depends on your own
I think it's just
knowledge.
about to expire. So, Dr. Gallagher, could you provide the committee with any additional data that could shed light on the issue of access?
Yes, I certainly could. There's a number of studies I could send.
Thank you very much. Next, we'll have Mr. Maloney. You have 5 minutes.
Thank you, Madam Chair, and thank you to all of our witnesses for being here today. Your presentations have been very helpful. I'm going to start my questions addressed to the Dorothy Lay Hospice. And so full disclosure to fellow committee members, the Dorothy Lay Hospice is located in Toronto and Etobicoke in my community. So I'm very familiar with the good work they do, and I want to thank you for that. But because of that, I had occasion to participate in a Zoom call that was hosted by Dorothy Lay a few months ago. I believe it was in July, during which they invited people to come out, and you outlined the process involved in MAID with some statistics. And the thing, many things struck me that evening, but the one that landed the most was the doctor that was doing the presentation suggested that when MAID was first legalized, that none of the, and I believe it was 12 doctors at Dorothy Lay, were wanting to be involved in the MAID process, whereas now that number had changed and the number was, I think, 6 or more. If I am correct in that, I would like to hear your explanation of why that is.
You are muted at this time, Ms. Cansfield or Ms. Perdue. Would you unmute? Have we lost them?
Yeah. Hello.
Oh.
Sorry.
Okay,
Yes.
go ahead.
I turn on my camera and then my mute button goes away, so I do apologize today. Yes, thank you so much, Mr. Maloney, for highlighting that. Since 2016, we've seen a substantial change. We've just completed a review of not only our palliative care physicians, but all of our staff, and in terms of their perceptions and thoughts about MAID. About 70% of our physicians have changed their perspective, and the reasons why they've changed their perspective is, I think they've stated that MAID has become more commonplace, more accepting. People are more accepting of it, but they've also seen that MAID can be one of the options that's in their toolkit as it relates to palliative care. So when all other options for comfort, symptom management, and in terms of relieving distress and suffering fails, and the individual is still suffering and is still asking for other solutions, they would never offer MAID. But if the individual brings up MAID, then they would have those conversations with them and exhaust that option for them. So I think that they have changed and evolved to consider MAID as one option in the toolbox of options that exist for palliative care, versus seeing MAID as something separate and distinct from palliative care.
Thank you, because there's been some evidence before this committee that it's an either-or situation. It's MAID or palliative care, and if I understand you correctly, that the doctors at your facility have come to the conclusion that it's part of the process, it's not an alternative.
Absolutely. So it's just one option. It's not a substitute for all of the other palliative care options that exist. And I think what we, in our experience in working with individuals who are thinking about or requesting MAID, it is that informed choice. It's that informed decision that they're making. And that's what our palliative care team does. They talk to the individuals and families about what their choices are. Why are they making this choice? What's driving behind it? What is their fear? What is their concern? And talk to them about all of the options that might exist to address them. And then at the end of the day, if MAID is still something they wish to choose, they will support them in that. So I think in the process, MAID is one aspect of palliative care, but it has to be an informed choice, and individuals need to understand that there are other options available to them. And if after all of that, they still wish to proceed with MAID, then I think that's something that we would support.
Okay. Access to palliative care is funded through the province. In the province, we all agree here there's a severe lack of palliative care. But my question is, because MAID is available, should it be restricted in some way or limited because of that lack of provincial funding? And I'll put that out to all the witnesses.
I'll take it on.
Okay, Dr. Gallagher.
I'd like to make the point, and I think my colleague from Dorothy Lay also made it, that a person who has to choose between MAID and no funding doesn't have a choice. And we've had several episodes like that in BC where people could not get access to round-the-clock care, so they could not stay in their community and were offered either a transfer out of their community or MAID.
Sorry to interrupt. My question really was, should MAID not be available because of lack of provincial funding?
We're out of time. Thank you. Next, we'll go to Monsieur Thériault for 5 minutes.
Merci beaucoup.
Thank you very much. Dr. Gallagher, do you practice, do you use palliative sedation?
Do I use palliative sedation?
Oui.
Yes, that's my question.
Est-ce que vous pratiquez la...
Do you also offer medical assistance in dying?
No, I do not, although I should tell you that I'm retired clinically since 2019, but when I was practicing, I did not provide MAID.
Thank you. Why is it morally more acceptable to you to provide palliative sedation than it is to provide MAID?
Thank you for the question. I'm not making a statement about morally. I provided palliative sedation very rarely, mostly for people with delirium at the end of life, because it was very difficult to keep a person comfortable and in their bed and calm if they did not have some degree of sedation. The use of sedation is not to end the life of the person. It is to make them more calm and make their symptoms more controllable. So they are not the same.
Oui.
Thank you. But was it the patient that gave consent for that type of care?
Oh, yes.
Okay.
It is.
Donc,
and,
les soins palliatifs.
So palliative care can be used to calm existential distress and anxiety at the end of life. And so you would offer palliative care. Did you also offer the option of MAID?
I'm not clear on your question. Are you asking me if I offered palliative sedation for existential suffering?
En fait,
No. The patient that you mentioned, for example, who is in a state of anxiousness, who has delirium, and the medication hasn't managed to calm that suffering because palliative care can't deal with all suffering and pain. I imagine you agree with that. So if you provide palliative care, do you also offer the option of MAID?
Well, first, I would have to say that delirium is a syndrome where a person is hallucinating and is often very confused and trying to climb out of bed and maybe quite agitated. And that is a different syndrome from someone who has anxiety and existential distress. So,
mais alors comment faisiez-vous?
So how did you get free and informed consent from your patients? Why do you feel that that is more acceptable than a process where at a certain time the patient can decide, I would like to end this, I would like to have MAID? Why do you feel that what you offer is more morally acceptable?
I'm not saying it's more morally acceptable. I certainly work very hard to deal with someone's existential concerns. And if you recall in my talk, I mentioned how interconnected all these spheres are and that palliative care has a lot to offer for people who are suffering.
Oui, mais moi, je vous la pose la question.
But my question is, I understood what you have said, but my question is that often there is an objection on the basis of conscience. That's my question.
Move to Mr. McGregor for 5 minutes at this time.
Thank you very much, Madam Co-Chair, and I'd like to echo my colleagues and thank all of our witnesses for helping guide our committee through this study. Dr. Gallagher, I'd like to start with you. I think I take it from your comments that, that patient-centric approach is very important to you, just really trying to understand what patients want. And we've had a number of witnesses in previous meetings. Like I had Dr. Valerie Masuda from my own writing. She's a palliative care physician. We had a representative from Therapsil who specializes in psilocybin and psilocybin therapy. And we also had comments from Dr. Jose Pereira, who indicated a willingness to explore further research in this area. Because you mentioned the existential distress, and there has been some promising research, notably from Johns Hopkins University, on how carefully administered doses of psilocybin with the care and attention of someone who has expertise in this kind of therapy has really allowed patients, particularly at end-of-life care, to, I guess, gain a measure of acceptance in meeting their end. I'd just like to hear from you, what's your understanding of the state of research into that? Do you think our committee can make some recommendations in trying to make sure that type of therapy is more widely available to patients in palliative care?
Yes, I definitely think there's a lot more work to be done on dealing with existential suffering. And I think we're relatively early into a detailed understanding about existential research and how to offer therapeutic ways to mitigate this. And I think, there's good promise for this, and I would certainly support that. I actually took a little part in the training of Dr. Masuda and know that she is a great resource to her community. And I think we should explore this. However, I don't want you to go ahead and do that without mentioning all the other things that I mentioned about being able to measure the kind of quality of care we're giving to people and to enact standards, because that's the way we raise the bar across the country.
Yeah, and taking that into stride, but I guess, recommending further federal funding and research into this area is something you would support.
Yes,
yeah, okay.
Absolutely.
Perfect. I'll also turn it to the Canadian Cancer Society. Same theme, just, I know a lot of cancer patients do end up in palliative care. Some choose to access medical assistance in dying, as is their right. But just on the same theme of, this, what seems to be promising research in the use of psilocybin and psilocybin-assisted therapy, does the Canadian Cancer Society have any comments on that, and what recommendations our committee might be able to make in this specific area?
Thank you very much for the question. We are certainly exploring that. I think we understand one of our research projects is associated with that. So we're going to try and get more information back to you on that. We have certainly called for more access to funding for palliative care research, specifically in this area. The Quality End of Life Care Coalition has an ask, particularly around seed funding for research. This is a very difficult area for which matching funds for research is hard to raise. So we would ask, we'll make sure to send that submission to you so you can understand more context around that and the challenges in accessing research funding for palliative care.
Thank you. And then maybe in my final minute,
1 minute, yes.
I know that, when it comes to palliative care, I don't know if we've spent a lot of time speaking about the caregivers and the emotional strain and the financial strain that they can go through. Do you have any I guess I'll turn this to Dr. Gallagher. Do you have any comments about the supports that are currently available to caregivers and anything that you would like to see us recommend in that area?
That's a great question. And I would say, first of all, that people who are connected early to palliative care show a reduction in caregiver distress. And show benefits even after the person has died. I also think, though, that what we need are sort of some financial benefits and helps for caregivers, because many patients and caregivers report those out-of-pocket expenses when they have an illness that one never thinks about till you actually have an illness and have to go back and forth to the hospital all the time, etc. I also think we could look at things that aren't tax credits, because there are people who are poor enough that they never pay tax, and so they don't benefit unless they're refundable tax credits. So there's many more things that we can do, because caregivers, we could not manage our healthcare system without caregivers, and I would hate to think what it would be like without them.
Thank you, Mr. McGregor. I'll turn this now over to my co-chair for questions from the senators.
Merci, Senator.
Thank you, Senator. We will now go to questions from senators. Senator Meji first. Thank you, Mr. Chairman. My first question is for Dr. Gallagher or perhaps one of the other witnesses may have something they would like to add. We have heard among our witnesses before the committee that the level of access to palliative care across the country is very low. In fact, one witness from Quebec said that it depended a great deal on the postal code of patients. What do you think the federal government could do to try to reduce those disparities? First, Dr. Gallagher, and then if others would like to chime in, please do.
I think it would. Thank you. I think it would make an enormous difference if we had accessible high-speed internet and telehealth accessible to all people. For instance, when I went to Haida Gwaii, I found out how poor their cell service there was. So the nurses, in order to make a call, had to go to the beach to get cell service. And they couldn't access any of the apps on their phone unless they were downloadable. So that meant no house calls to the person at home. You know, I mean, we've got the technology to bring palliative care to a much better accessibility. But I'm afraid it's going to cost money, but I think there would be enormous benefits along with that. The other thing is if standards, I can't say enough about standards for palliative care. So we are measuring, we are establishing the quality we expect every person to receive. Thank you.
Merci. Thank you. I have a question for the Dorothy Lay Hospice representative, because I, in my career, set up a hospice in Laval, which has a similar mission. So could you tell me where your funding comes from? Is it federal or provincial?
Thank you for that question. In terms of our funding, 60% of our funding is from the provincial government, and 40% of our funding we must fundraise. So that's about $1.5 million a year. And that's a significant strain on us, and it's growing every year because the operating costs are growing. And so when you talk about accessible, high quality care, funding for hospices is certainly an issue that needs to be addressed. And in terms of caregivers...
Sorry for the interruption, but we're not getting translation, the French translation. So I think if you can speak slower in your response, that will help with translation. Thank you. Sorry for the interruption. Go ahead.
Can you hear me now?
Yes.
Hello, can you hear me?
Yes.
Yes? Okay, so I had indicated that 60% of our funding comes from the provincial government and 40% of our funding we must fundraise. So that's about $1.5 million, and that's growing every year. And so when we talk about accessible, high quality care, we need to look at funding for hospices. And in terms of caregivers, one of the other things that's really essential for caregivers is just information, support, advice, guidance, counseling along that entire journey. That is what we do at the hospice. We have exceptional staff who do that work. And I can't tell you how much distress it relieves for caregivers and for the individual, and how it helps keep people home. So some of those social supportive services, the volunteers
Thank
that
you.
go into
Thank you, Ms.
home
Cansfield. Thanks, Ms. Cansfield. We'll go to Senator Kutcher for 3 minutes.
Think they're hearing.
Thank you very much, Chair, and thank you to all the witnesses, and really appreciate you reminding us that we have huge challenges in improving equitable access to high quality medical care across Canada, and absolutely this includes palliative care. My questions, I have two to the Dorothy Lay Hospice group. And then the second one. I understand that the hospice provides high quality palliative care, but you still see patients who request MAID even though they have received high quality palliative care. In these patients, is the statement that their request for MAID is due to not receiving quality palliative care, or did they choose MAID even after they did receive high quality palliative care for another reason?
Yes, absolutely. So individuals that request MAID in our care here at the Dorothy Lay Hospice have received high quality palliative care. However, as I said earlier, they are choosing palliative MAID because of a reason, which whether it's because they don't want to die, have their family watch them die and suffer in that way, or it's a choice for them, or their suffering still isn't relieved with all of the other options with palliative care. So again, high quality palliative care often prolongs life, often provides good quality of life. It doesn't mean that nobody will access medical assistance in dying, but it does mean that people will be making an informed choice of whether medical assistance in dying is really what they want to address their worries, their concerns, their distress, their pain, or are there other palliative care options that might assist them?
Well, thank you for that. I wholeheartedly agree with what you said. We've heard concerns that people are receiving MAID because the quality of palliative care that they get is poor. Would you know of any data that shows that the people who have received palliative care and then chosen MAID have done so primarily because the palliative care that they have received?
I don't have data. I do have anecdotal data and understanding the high quality, the level of palliative care that our organization delivers. I can certainly say that they are making the choice because it is something that they want. I would say in my experience though as a nurse in palliative care for many, many years, that people do choose I have seen over the last many years, people choose medical assistance in dying if they can't get enough home care to support the caregiver to keep their loved one home. If they can't get into the hospice because there are not enough residential beds. I have seen that as well when they're not able to access palliative care in terms of the level and standard that I think Dr. Gallagher talked about. They may decide to choose medical assistance in dying.
Thank you, Senator. Senator Delfont pour 3 minutes.
Senator Delfont, 3 minutes, please.
To the witnesses for their contribution to our work. My questions are for the representatives of the Canadian Cancer Society. You said that, if I understood properly, that 67 of MAID requests are related to people suffering from cancer. Can you tell us, do you have data about how many of them were receiving palliative care?
Unfortunately, we do not. The quality and availability of data on palliative care access, especially in relation to MAID, is not disaggregated in that way.
And based on your experience, is there a spectrum of palliative care? So it starts first at home and then it moves to a special place afterwards?
So it depends on very much. In an ideal scenario, it would depend on the situation in which the wishes of the person receiving care. People could choose to go to a hospice if that's available to them, or receive it at home, or receive it in a hospital or a long-term care home. We think in an ideal scenario, they should be able to choose where in which they receive care. Often it's their primary care provider specialist who identifies and transfers them to a palliative care specialist, but that can occur in many different settings.
But are they asking to stay at home as much as possible? Or do you prefer to be in a specialized center where they feel there's more kind of care and they are feel reassured?
In the polling that we have done, more respondents tend to say they would prefer to die at home, but in individual circumstances differ depending on each individual case. Often, I would also say hospices aren't often available, particularly outside of urban settings. So the choice to live at home, to die at home, might be because of a lack of different options, not necessarily because that's where their preference is.
Will it be possible to provide to us the result of that survey or that
Absolutely.
research? Thank you.
Thank you very much. We'll now go to Senator Martin for 3 minutes.
Thank you. And thank you to the witnesses once again for providing us with such important insights. My question is for Dr. Gallagher. As a representative of the Canadian Society of Palliative Care Physicians, why should MAID remain distinct from palliative care?
Yeah, thank you. There's a number of reasons for that. Really, you know, for about the past 40 years or so, palliative care has been striving to show people that we do not hasten death and we do not shorten their life. And so the problem with combining us with MAID is this confusion. So that's one of the reasons. The other reason, and that's supported actually by a 2021 study of public knowledge and attitudes concerning palliative care, and this was Canadian people, and they found that those who had a high perceived knowledge about palliative care were more likely more likely to associate it with care provided as a last resort at the end of life. So despite 40 years of work, people were still associating palliative care with end of life. And so combining MAID into palliative care would definitely cause that. The other reason is that there are still people who have fears that palliative care somehow shortens life. And I've certainly met people like that who have fears, particularly with the so-called opioid crisis. Many people are fearful of actually using opioids. So we have to work hard with that. So we do not want that. The other reason why is that when MAID was first legalized, many healthcare providers, not understanding either palliative care or MAID, just sort of thought, oh, palliative care will deal with this because they deal with all the end-of-life stuff. It was very chaotic. And I guess our concern is that if we went back to that, for healthcare funders, that probably seems like the ideal thing, because then everything's kind of jammed together and you have no extra funding, you have two programs coexisting together, which would be cheaper. And we do not feel that that would provide quality care. The other reason is it's been our experience that providing certain cases of or situations with MAID actually ends up consuming palliative care resources. As we've told you tonight, there's problems with accessing palliative care. We have the same human resource
If you could complete it quickly, Dr. Gallagher.
Yep, thank you. We have the same human resource challenges as emergency department everywhere. So we would like to use our palliative care resources to provide palliative care resources to all Canadians, obviously including those who want MAID, but we do not specifically want to be, we want to be seen as distinct from MAID. Thank you.
Thank you very much. That brings our first panel to a close. I'd like to thank Dr. Gallagher, also Ms. Masotti, Mr. Nowoselsky, Ms. Cansfield, and Ms. Purbu for your testimony this evening and for answering the questions from this committee on the subject of palliative care and the issue of medical assistance in dying. This is very important for us to hear from you. We very much appreciate that. With that, we will suspend very briefly as we prepare for our next panel. Thank you.
Thank you.
Understanding that there is agreement. This is a truncated session because there's a vote in the House, and so we'll go until 8:20 p.m. And everyone's times, it has been agreed that will be truncated and shortened by 1 minute. So both MPs and senators, all of us will give up a minute of our time so we can truncate this second panel. So I want to welcome our witnesses for the second panel. Thank you so much for lending us your time and your expertise. We have, as individuals, Baroness Elora Finley, Baroness of Llandaff and Professor by video conference, Dr. Henderson, Senior Medical Director, Integrated Palliative Care, Nova Scotia Health, and he is here in person. And lastly, Dr. Madeline Lee, psychiatrist and associate professor by video conference. Thank you all for joining us. We will begin with opening remarks by Ms. Finley, Baroness Finley, followed by Dr. Henderson, and then Dr. Lee. You each have 5 minutes. So Baroness, go ahead.
Thank you, and thank you for inviting me. As legislators, and I'm a legislator, we must ensure that legislation's protective role of the vulnerable is reinforced, not weakened, and the state's duty of care is fulfilled equitably as exercised via its clinical workforce. Canada's physician-assisted suicide and euthanasia deaths show a disproportionately rapid increase even compared to Benelux countries. Removing the foreseeable death requirement, in effect, creates death on demand. Evaluation of patients is purely subjective, and consultations have never been qualitatively evaluated. Doctors have an inherent power differential in a consultation. Offering lethal drugs as a therapeutic option gives the subliminal message that what lies ahead is so awful you would be better off dead. Subconsciously, this may reflect unconscious bias or ignorance, shortcuts in care, or cost-saving motives. The so-called safeguards are only broad qualifying criteria rather than verifiable safeguards. For example, foreseeable death was incredibly loose, as prognostication is notoriously inaccurate. According to the Royal College of General Practitioners, prognosticating beyond a few days has a scope of error that can extend into years. And doctors, by their very compassion, often fail to detect coercion. UK data reveals 1 in 5 elderly people affected by abuse, particularly financial abuse and neglect in their own home. Similar situations seem to exist in the other countries in the developed world. Mental capacity impairments and distorted thinking is a feature of mental illness with or without concomitant physical disease. Most clinicians are inadequately trained or experienced in assessing capacity. Hence, including mental illness undermines suicide prevention policies and discriminates against those with mental distress by signalling they don't warrant ongoing psychiatric care and are of less value in society. The emerging accounts of those in poverty who are opting for MAID suggest an abandonment of society's duty to care for this group of citizens. Yet many who strongly wish for death at one time later enjoy life and contribute to society in many unpredicted ways. The drug mixtures used to end life have never been scientifically evaluated. Propofol's duration of action is short, 5 to 10 minutes, as it's rapidly distributed in the body. Yet rocuronium has a very long duration of total paralysis, making it likely that some patients will have regained consciousness as they die of asphyxia, but appear to the observer to be tranquil, as they cannot move a muscle to signal distress. Good palliative care does not include MAID. In my written submission, I gave 3 definitions of palliative care. All emphasize improvement in the quality of life of patients and their families and carers, aiming to help people live well until they die. Distress and suffering requires meticulous diagnosis, working with the patient, particularly where distress is amplified by financial worries, loneliness, fear, and hopelessness. Any improvement can often be obtained very rapidly. I could give you an example of a man who referred with overwhelming distress, and his wife and daughter, both in tears, had pain and nausea controlled within an hour, and all 3 commented they never believed things could be so greatly improved. Medical assistance in dying is a euphemism for physician-assisted suicide and euthanasia of those thought to be terminally ill. It cannot be applied when the previous requirement of foreseeable death has been abandoned, because those being given lethal drugs are not dying. In summary, Canada would do well to abandon the current expansion of its MAID law, which is an existential threat to those with disability or mental illness. Canada should invest in adequate specialist palliative care and move the provision of lethal drugs outside healthcare, with prospective evaluation of the application consultations, research into the cocktail of drugs used, and research into the short and long-term effects on the bereaved. Thank you.
Thank you very much. And next we will have Dr. Henderson for 5 minutes.
Thank you. Everyone able to hear okay? Yeah, good. So my name's Dave Henderson. I'm from Nova Scotia. And I've been asked to speak really as a palliative care physician. I'm also a former president of the Canadian Society of Palliative Care Physicians a few years ago, actually, when MAID was initially starting up in Canada. I'm also a former president of both the New Brunswick and Nova Scotia Hospice Palliative Care Societies and a former board member of the Canadian Hospice Palliative Care Association. And I currently chair a group that we call Palliative for Canadians, which actually is made up of the senior leadership from 4 different organizations in Canada. That sole reason is to try to improve palliative care for all Canadians, that being Canadian Virtual Hospice, Pallium Canada, Canadian Society of Palliative Care Physicians, and the Canadian Hospice Palliative Care Association. I'm not going to reiterate a lot of the great comments that have been made by many of my very well-esteemed colleagues. You have all that information. So I wanted to speak about some other issues that I felt were very important as we were looking into this issue. I wanted to start off by saying that I'm not a religious man, and I've said on several occasions and several different presentations I've done that I'm pretty sure I'm going to be going straight to hell. I look forward to seeing many of you there as well. And that's my standard token maritime humor, if anybody missed that. So, but unfortunately, many palliative care physicians who have made any kind of seemingly negative comments towards MAID is quickly looked at as being overly religious, or there's other reasons why they've had concerns. And I wanted to make it clear that I actually refer to colleagues of mine that provide MAID, so I'm not against it from that perspective, but I see a lot of concerns, as do some of my colleagues that I work with who actually provide the service. So I think it's really important that we look at these. So my theme tonight is actually time for a reality check. So just firstly, looking at healthcare in Canada, to me, is in its most fragile time that we've ever experienced due to the lack of planning for our exponentially aging demographics we're currently living in. Not only are the numbers of Canadians reaching the ages where most need more healthcare, especially in hospital, but the healthcare workforce is also among this aging demographic. So what we're seeing with that is new healthcare professionals no longer have the comfort of having seasoned colleagues to mentor them as they start their careers. Many are feeling moral distress and overwhelmed as they're subsequently leaving healthcare in general. And I'm sure you've all have heard of that. The numbers are quite staggering, even for a lot of the young health professionals who are just getting out of healthcare altogether, which is a terrible shame, and is putting this country in such a delicate, desperate situation. Subsequently, this is leaving our patients with less experienced providers, having to take on workloads they're not used to, without having had the opportunity to gain the knowledge and skills to meet those needs. This creates difficulties for all patients, but especially those who are dying or those in vulnerable positions, as we've talked about with our poverty issues and many other issues faced in our country. I'm very concerned that this opens the door to medically assisted death as potentially a path of least resistance, as we see people getting more and more overworked and tired and exhausted, that unfortunately this could become an easier pathway. Things tend to take the path of least resistance. I'm concerned that the government has given healthcare professionals essentially a license to kill, without having significant checks in place to ensure people are assessed properly and thoroughly, and that comment was made up just minutes ago. Canadians agreed that people living with a terminal illness with foreseeable death be given an opportunity to seek voluntary euthanasia, and the laws were amended. Many people spoke up at that time about the worry of the slippery slope and were quickly dismissed. Here we are a very short time later with MAID virtually being available to any person for any reason. And I ask, is that what the Canadian public actually wanted or wants? If the majority of the society feels that autonomy trumps all, as seems to be becoming the way, that every person can end their life after choosing it, so be it. But we still are responsible to protect the vulnerable and ensure that people have a choice that includes access to palliative care, mental health, social supports, pain specialists, and a healthcare system that allows for dignity for all, not just those who want to end their life. I want to make reference to testimony that has come previously, again, from colleagues such as Dr. Leonie Herx and the Canadian Society of Palliative Care Physicians, who have outlined some of their concerns and ideas of how to remediate some of these. We've had, I know you've
Sorry,
heard
Dr.
from...
Henderson,
Sorry.
time, will you wrap up at this time?
So ultimately, I'll finish at this point. Thank you.
About that.
That's okay.
I should have given you the 1 minute warning, but I was like listening to your speech. Lastly, we have Dr. Lee. You have the floor for 5 minutes.
I'd like to thank the joint chairs and the committee members for the opportunity to participate in this study. I'm a psychiatrist at the Princess Margaret Cancer Centre, an associate professor at the University of Toronto, and a scientist with a research focus on emotional distress and suicide in cancer, and this includes MAID research. I led the development of the MAID program for the University Health Network, served as an expert witness on the LAM case, and am currently the scientific lead for CAMAP's MAID curriculum development project. However, I'm speaking today as an individual, so all opinions expressed are exclusively my own. I'm also a MAID assessor and provider, and what I'd like to tell you today is that I have significant concerns about the pace and process of the expanding MAID legislation. I'd like to begin by recognizing that practitioners all have values that sit on a continuum of whether they prioritize patient autonomy or the protection of vulnerable persons. I personally lean more towards the duty to protect, largely reflecting my belief that MAID for those with a reasonably foreseeable natural death is literally assistance in dying, while MAID for those without an RFND is technically assisting a suicide. This opinion underlies the 4 points I'd like to make. My first point is that there's been insufficient attention to the psychological dimensions of palliative care. Given that psychological suffering has clearly been shown to be the primary driver of the desire for MAID, we've not adequately captured data on access to psychosocial care or emphasized the need for targeted research and funding in this area. Secondly, as was just said, I've yet to see a public opinion poll on whether the Canadian populace is in favor of MAID for all forms of life suffering, and in particular for psychosocial or structural vulnerability. It's an important question because I believe the Canadian populace and maybe even the legislators are not aware of who has been qualifying for MAID. I suspect it may come as a surprise to learn that what are essentially completed life cases have been happening in Canada even before C7, because no one reaches older age without some form of qualifying chronic illness like arthritis or COPD or diabetes, and psychosocial vulnerability often underlies these requests. Conceptually, MAID and palliative care are arguably distinct, but clinically, I believe there needs to be better integration in order to ensure high-quality end-of-life care with attention to vulnerability. The thing is, everything about MAID, except for the 5 minutes of the lethal injection, is palliative care. All the initial conversations with the patient about whether to apply for MAID, optimal symptom management until they do, guidance about choosing when to go ahead with it once they're approved, support for the family after they've received it, are all really most safely done by palliative care. But to engage the palliative care community, we need to demonstrate that we're practicing MAID carefully, consistently, and for palliation. But the legislation hobbles us in this. I've certainly had cases where I felt compelled to provide MAID against my better clinical judgment because the law did not adequately protect. I'd be happy to describe such a case if asked. This leads to my third point, that the current legislation leaves too much responsibility in the hands of clinicians, whose application of the eligibility criteria according to their own values can render the legislated safeguards impotent. Also, as was said earlier, this is because incurability can include treatment refusal, an advanced state of decline may not need to be progressive, suffering is determined only subjectively, and reasonably foreseeable is not legally defined at all. The absence of a definition of RFND is crucial in light of C7, as patients with prognoses of several years or who refuse preventive care or who voluntarily stop eating and drinking can be placed on the supposedly palliative track 1, where there's no longer even the mandatory safeguard of a 10-day reflection period. This brings me to my final point, which has also been made, that Canada needs some standard mechanism of oversight to review cases. This has been proposed for mental illness as the sole underlying medical condition, but I believe it's required for many MAID cases, or at least for all Track 2 cases. In sum, I'd like to see 4 things: increased attention to the psychological dimension of MAID, whether there's a public mandate for MAID for any form of suffering, a legal definition of RFND, and some form of federal oversight. Under what circumstances a person should receive MAID cannot be left to the variable opinions of individual practitioners, because it's the responsibility of the government, which really should reflect the will of the Canadian people. Thank you.
Thank you very much to all of our witnesses in this second panel. We'll now go into the first round of questions, and as agreed, it will be 4 minutes for each MP. So we'll go to Mr. Barrett for 4 minutes.
Thank you, Madam Co-Chair. Baroness Finley, my question's for you as a member of the British House of Lords who has studied euthanasia regimes, and with your professional background as a physician and a professor with attention to palliative medicine, how, in your view, is Canada being perceived from abroad regarding our MAID policies and practices?
I think if I could put it very simply, it's being viewed with great concern because of the rapid expansion, the stories that are coming out in the press of people who are opting for MAID because they can't pay their bills, they're frightened financially. That isn't a valid medical reason to have doctors end lives. And there's also concern about extension into mental health because of suicidal ideation, which can fluctuate, and people can go on to live very full lives if they're taken through their crisis and supported. So it is viewed, I think, with great concern.
Thank you. So this committee has recently heard testimony that Canada should consider expanding MAID to infants with a life-limiting prognosis in order to address the terrible suffering that those infants might undergo. Now, I must note that I fundamentally disagree with this suggestion because I believe it devalues persons with disabilities and that no child should have a question mark put over their life because society deems that life to be optional. But can you tell us about the field of pediatric palliative medicine and whether MAID is the compassionate choice in those situations?
I would say that it isn't a compassionate choice at all. It might be a convenience for people, and certainly the long-term care of a child with a lot of disability may be financially draining and emotionally draining on the family. But if you're going to focus on the child, you have to have evidence that the child is suffering. You have to have evidence that the child wants something different to their current existence. And you have to be careful that you're not reflecting a disability phobia within society and a discordant view of disability. And there is a real difficulty about where would you put the line anyway.
Thank you very much. Dr. Henderson, how have palliative care resources been impacted by the implementation of MAID legislation in Nova Scotia and elsewhere in Canada?
Ultimately, we haven't seen a significant increase in human resources at all. I know there was a colleague of mine who talked about things being a lot better in one spot here in Ottawa, but that's very few and far between. We're struggling. We have wait times for patients for access to palliative care in Nova Scotia. And again, I mentioned about even the challenges now faced on the palliative care teams, partially because we are part of the aging demographic. So we're not keeping up even with those palliative care specialty teams who are retiring. We're not producing new specialists quickly enough. There aren't enough positions open for training in Canada. And that's something we've been talking about for quite a while with the universities to try to increase that. Also, the lack of primary care. News just came out yesterday in Nova Scotia. Ultimately, we've got a population of about 1 million people, so respectively, it's not that large compared to other places in the country. However, we're short now about 120,000 people don't have a primary care provider. So that's like 1 in 10 people in our province. So those people don't even have access to primary care, let alone the only way they receive palliative care is they end up in an emergency department, subsequently get referred. Then our palliative care teams see these people and virtually have to hang on to them because there's nobody else to care for them. So that's creating another load on our palliative care teams. And it's becoming more and more challenging.
Thank you very much, Dr. Henderson. We'll next go to Dr. Fry. You have the floor for 4 minutes.
Thank you very much, Chairs. I am listening to the two panels, the one an hour ago and this one, and I must say that some of the things I hear concern me. First and foremost, I buy and I accept the idea that we need to have palliative care accessible across the board. And we know that provinces are responsible for that. So we need to look at some kind of universal accessibility, regardless of where you live in Canada, to good palliative care. I hear that we don't have enough human resources to deliver palliative care, especially specialists to deliver palliative care. So I'm hearing that and I buy all that, I accept all that. But what I am a little concerned with is that does anyone on this panel believe that palliative care and MAID are actually interchangeable, that or that they're separate and that you might have one or the other and not that it's a continuum of care, that if palliative care does not work, if a person's existential suffering becomes so great, and who are you or me to say that somebody is not suffering existentially? How do we know that, especially adults? I mean, I accept the question that small children don't know and can't articulate. But for many adults, existential suffering is exactly what that is. And we know that sometimes can, and we heard it from one of the panelists in the last hour, who said that some people get great palliative care, and yet they just don't want to continue because whatever they're feeling, whatever they're suffering, is just too much. So my question is this: if all things being, likely that we have great palliative care, that we get money put into it, that it is universally acceptable, that we have enough human resources to train and deliver good palliative care, my question is this: could a person who is undergoing that with the ability to get it without any problem about their ability to pay, which is, as we know in Canada, medical care, it means that you shouldn't have to worry about ability to pay. So if we get all the support systems in place, do any of you believe that a person should be forced to stay in palliative care and not be offered MAID if they so choose? I notice Dr. Lee is shaking her head. So perhaps, Dr. Lee, I'll direct that question to you first.
I absolutely take your point. I support the availability of MAID for end-of-life patients. And I certainly agree that I don't think for the minority of patients who want MAID and go ahead with it are doing so because of a lack of access to palliative care. I think that the question was asked, I think at the last panel, about what proportion of patients who receive MAID have access to palliative care. And the last federal report tells us that it's 82% of people who have received MAID have also been in receipt of palliative care, but it's also, the criticism of that was that it's clinician reported. At UHN, my hospital, we have looked at actual receipt of palliative care services, and and it's closer to 100% of our oncology population who accessed and received MAID have also received good palliative care. So
thank you, Dr. Lee.
So there's 30
How many
seconds.
more minutes do I have, Chair?
30 seconds.
30 seconds. I'm probably going to make a statement and not ask a question. So my statement is going to be simply this: that I think we've had a lot of people asking what other people think about the Canadian system, what society thinks, etc. At the end of the day, the Supreme Court ruled that it has got to be Section 7 of the Charter with the right to life, liberty, and security of the person. And that means it doesn't really matter what other people think, and people, society in general, should not be judging whether you or one should choose palliative
Thank you,
care.
Dr.
It's
Fry.
It's a clinician who should work with the patient
Thank you, Dr.
to
Fry.
do that. Thanks, Chair.
Okay, so next we'll have Monsieur Thériault for 4 minutes.
Merci.
Thank you. Dr. Henderson, your theme tonight is that we need to be very careful, and I certainly agree with you that we need to have better palliative care services. But I would like you to explain what you mean when you say autonomy above all else. When, for example, we talk about MAID versus palliative care. What do you mean by that? Do you mean that everyone has the right to decide for themselves under the law with clear and informed consent? To me, that is autonomy.
Okay, thank you very much. From my experience, the majority of people that we see requesting MAID are people who are often well-educated, and I haven't seen very many people who have a lot of physical symptoms. So existential distress certainly is something, but more and more I'm seeing people who, again, it's that personal autonomy of just wanting to choose their time. They want to have a time when families can come and be present, and looking at almost like planning a vacation versus planning their death. It sounds strange, but it is strange when you experience some of that. My concern is that there's a proportion of the healthcare professions in this country and a proportion of the population who are really looking at having autonomy in the sense of this needs to be available for absolutely everybody. And I'm not saying it shouldn't be, but if before we push it that far, we have to remember that there are people who don't live a life of autonomy. They've been struggling with financial difficulties. They're responsible to other people. Other people are caring for them. So they don't get to make a lot of their own life choices already. That doesn't mean they shouldn't have this choice, but is it truly, do they perceive it as truly a choice? And that's the challenge and struggle there. And that's why I'm so concerned that we need to be extremely careful with this. I don't think we've had the proper checks and balances in place. I know we've heard across the country various concerns, and I never hear of any follow-up on those cases. So for a colleague of mine gave an example, for any of us to prescribe an opioid, there's provincial bodies who now monitor our prescriptions. And if a patient of mine got a prescription for an opioid from 2 other physicians, I get a letter saying, this patient has done this, and we're trying to make sure that the person's not using opioids inappropriately. Does anybody get a letter about a patient who's had MAID, or a physician who's done a large number of cases that gets checked?
I'm sorry to interrupt you. I have 30 seconds. You will agree with me that personal autonomy doesn't just mean economic or social autonomy. When we talk about the dignity of a person, it's that person's ability to make a choice. We don't want to take that choice away, the choice between continuing with the palliative process or to have support in a chosen death, because people don't decide all of a sudden. Thank you.
Yes, I was going to say yes or no. Thank you very much. Next, we'll have Mr. McGregor for 4 minutes.
Thank you, Madam Co-Chair. Dr. Henderson, I'd like to start with you. I had the opportunity to visit your beautiful province in September, and while I was there, we had the opportunity to meet with some members of the Legislative Assembly of Nova Scotia, and just trying to talk about that intersection between the federal government and the provincial government, specifically on healthcare. And one of the things they mentioned to me was that the way the current funding formula is working, well, it's not working very well for Nova Scotia because your demographics tend to lean heavily towards the elderly end of the spectrum. So, of course, the complex care needs and the palliative care needs are per capita a bit more of a burden for the province of Nova Scotia to bear. You have identified how healthcare in Canada is in crisis. My province of British Columbia, particularly on Vancouver Island, we do have a fairly high population of retirees as well. With what I heard from the MLAs, do you have anything to add from your perspective of having practiced, just about how that federal-provincial partnership is going? Do you have any?
That certainly comes down to the dollars and cents of it. And I've been kind of involved in this at the national level enough to know that, and we've tried as a group to try to bring together provinces, the provincial governments and the federal government, because politics often gets in the way of doing the right thing sometimes. I'm not the right guy to say how money should be divvied up and such, but I think we need to have real serious look at how we're delivering health care. It was brought up earlier about caregivers as well, too. And I think for our healthcare system to survive the next few years, I think we're going to have to look at how we can compensate our caregivers, because we're not producing enough professionals and allied health people to be able to carry the load. So.
I appreciate it. Thank you. I've just got to take note of the time here. In my final couple of minutes, Dr. Lee, I would like to turn my next question to you. In your opening remarks, you really made it a point to underline that the psychological suffering part of it, and certainly we've heard a number of other witnesses talk about the same. We've also had witnesses here. I've had a doctor from my own riding. We've had a representative from a company that is involved in psilocybin and psilocybin-assisted therapy. Because that particularly is involved in trying to help patients at end-of-life care come to terms with that existential crisis, that psychological suffering. Are you aware of some of the research that's been going on? Do you have any comments on that? Would you like to see the federal government invest in more research in this area as a possibility that it might assist patients with the quality of their care?
Thank you for that question. I have lots of opinions around this, and absolutely I would like to see more funding for psychedelic research, for psychosocial research in general, and psychedelics are a part of that. I would be wrong to turn that down, because I am running I've just submitted to CIHR for funding for a study on psilocybin in cancer and palliative care. So I certainly think that research needs to be done. I want to give a caveat that it's not going to be the panacea or antidote to MAID in any way. I finished a clinical trial looking at ketamine, another type of psychedelic, ketamine in palliative care. And I published a paper of a case series of 3 patients.
Thank you, Dr. Lee.
It doesn't necessarily change a patient's mind.
Thank you. Sorry, I think we need to just quickly receive, I see Gary's hand. It's probably related to the same matter.
Yeah, we see the bells are ringing, Madam Chair. I'm just wondering if we could all agree to continue the meeting for another 15 minutes to conclude with the Senator's interventions.
Consent? Okay, agree. Thank you, Mr. Ananda Sangari. I will turn this over to my co-chair for questions from the senators.
Thank you very much, and we'll begin with Senator Meiji for 3 minutes.
Thank you, Mr. Chairman. My question is for Dr. Henderson. In an interview you gave, you mentioned that many people are afraid of palliative care because they think when they are referred to palliative care, they're going to die more quickly. What do you tell them? And I'm asking my question quickly because you only have a couple minutes to answer. What role do you think the federal government can play in helping the public better understand palliative care?
We actually asked when MAID was initially coming along that there needed to be a national education campaign on palliative care, helping people understand what palliative care is, but then also what MAID is too, so the public were aware that this was actually available, which could actually help us reduce the risk of coercion. So if the public knows that it's available, then they ask us. And right now we rely on them making a suggestion that there's something or that life's intolerable, and then we will say, you know that this is legal. We discuss it further. But with palliative care, patients are still afraid to this day that we're going to get involved and they're going to die sooner. So we try to reassure people that we actually discharge people off our program all the time. People will come on our program, we'll help them address their physical symptoms, help them start working through some of their psychosocial issues, help make sure they've addressed things like advanced care directives, things like that. And if they're doing really well, then we step back and they continue on with their primary care people, plus their oncologist or whoever, and then we're able to get back involved again when necessary. So reaffirming that with patients and families helps to reassure them that we're not there for just the last days and hours of life.
Merci. Merci. Thank you.
Très bien, merci. And
very good. We will now go to Senator Kutcher for 3 minutes.
Thank you very much, Mr. Chair, and thank you to the witnesses. I have two questions. The first one to both Dr. Henderson and Dr. Lee, and then the second one to Baroness Finley. So I'll ask them together and then ask you to respond. Dr. Henderson and Dr. Lee, in your opinion, how could the federal government nudge provinces and territories to provide better quality palliative care to those who require it? That's the first question. And then Baroness Finley, has the National Health Service substantially improved palliative care in the UK over the last few years? Compared to Canada, what percentage of people in the UK have rapid access to quality mental palliative care? Thanks. Dr. Lee and Dr. Henderson first, if you don't mind, please.
Yeah, sure.
I'm happy to
go ahead.
Answer that. As I said in my statements, I think what has been missing, better quality palliative care, is a focus on psychosocial care, because that's what underlies existential distress, which is what psychosocial care addresses, is what underlies the request for MAID. And I think there has not been enough attention, and so more investment in research and the delivery of end-of-life psychotherapies, such as CALM or dignity therapy or meaning-centered psychotherapy. They exist, they're not disseminated, and additional research needs to be done on the dissemination.
I agree 100%. One of the things that, and again, I'm not sure if the federal government, I think the federal government passing down some words of recommendations to our professional colleges. So, and I'll pick on the College for Social Work nationally. They tend not to do any specialized training at all, but there's a great place and there's such a great need that the social workers in their training could be learning more about things like dignity therapy, because we tend to have to teach all the social workers a lot of this stuff when they come out before they start working in palliative care, because they don't get their core competencies trained in palliative care in their training programs. And Canada has done a really good job looking at core competencies for social work, for primary care physicians, for nurses, for almost everybody in the country. There's a national document that talks about that. Nova Scotia and British Columbia have produced their own provincial documents on competencies in palliative care for virtually all healthcare professionals. Those competencies need to be ensured that they get integrated within the professional schools so people have the skill sets to be able to deal with this.
Thank you. And Baroness, you have about 20 seconds for your question.
Okay, very rapidly. You have to differentiate generalist palliative care from specialist palliative care provision. We have just changed the law so that it is a core specialist palliative care and palliative care is a core part of NHS provision. One person not getting the care they need is one too many, I would have to say. Really the difference is between access to specialists and those who get general care. When the generalists can't cope, they should be referred to specialist palliative care. Specialist palliative care cannot look after everybody who's dying, but everybody who is facing the end of their life needs good care. And those skills are then transferable to other aspects of medical care of people with distress for whatever reason, including those bereaved because they've lost somebody suddenly or whatever. But those are transferable skills. And you must have standards that you measure against.
Thank you, Baroness. We'll go to Senator Dalphond for 3 minutes.
Senator Dalphond, 3 minutes, please.
My question would be for you, Dr. Henderson. You're so close. So, and I understand from the previous witnesses, and I think Dr. Lee mentions that 82%, even more, of those receiving MAID had previously received good palliative care. Will you agree with this or not?
No, I actually don't. We don't know that for sure. Well, the thing we do know is that 18 to 20% of those people, first off, didn't receive any palliative care from that study. There was another 20% that only received palliative care in the last 14 days of life, and that's not enough time, especially if you're dealing with psychosocial suffering. You don't fix or remedy that in 14 days.
Yes, based on your experience, you're not a MAID provider, you're a palliative care provider. Have you seen many of your patients that after a certain moment did ask for MAID?
Oh, yes, for sure.
And would you dismiss the request or you will agree to the request?
No, we actually teach also, we never abandon the patient. So there was a comment made about having to choose between MAID and palliative care. If the person's receiving palliative care, they can continue to receive palliative care right up until the time they have MAID. We don't intend it ever to have to stop unless the patient does not want to continue with palliative care. So it's always available. So we teach, and we've taught for years and years before this became available, when someone says they think life's not worth living, we start by exploring that. We inquire, what do you mean by that? So they can say, I don't feel I want to live anymore. And then we talk about what's the root cause of that. And that's one of the things that lacks in a lot of the assessments for MAID without palliative care being involved. The assessment only involves, do they qualify for MAID, not asking the question, what's the root cause of your suffering and how can we fix that?
And you say that because you did some MAID assessment?
No, because I work with people that have done MAID assessments and actually was involved with developing the policy and developed a tool to help people who didn't work in palliative care to be able to do assessments, only to be told that that'll take too long.
Thank you.
Thank you very much. And with that, the panel is coming to a close. I want to thank our witnesses this evening, Baroness Finlay, Dr. Henderson, and Dr. Lee. Thank you for your forbearance with our slightly compressed schedule. I beg your pardon. My mistake. I forgot one of the senators. My own co-chair. I'm in trouble now. Please go ahead, Senator Martin. You have 3 minutes.
Thank you. My first question is to Dr. Henderson. You mentioned earlier in a response that we haven't had the proper checks and balances in place. So I wanted to ask, how can we improve oversight and monitoring of MAID to ensure Canadians are not choosing it because they lack the access necessary, lack the necessary resources needed to live, including palliative care? So what is needed?
So again, I'm not the expert on this. I think this is such an important thing, and it's such a definitive thing. Somebody's life ends with this. I mean, there's not much more importance than that we need to make sure we're doing this right. And Canadians, it's legal now, and it's something that is being used. We just need to make sure we're doing it right. So I think there needs to be an oversight body, and perhaps not even within the government, but some form of oversight body who has the ability to review cases. And there needs to be some national guidelines around what cases do you review. If somebody doesn't follow the guidelines, what are the consequences for not following through those. So physicians don't get surprised at the end of the day that they, in good faith, they've provided MAID only to find out they did something wrong and they had no idea what their consequences were going to be. Those things all need to be very much cleared up, very transparent, so everybody knows the game, what the rules are. To me, there should be audits of, I think you could flag high producers, basically. People who are doing a lot of cases probably should have more of their cases audited to make sure that everything went well and everything was above board. And then just random checks on other people providing the care. That's what happens already in healthcare for family physicians and all physicians, that, at different times our charts can be audited just to ensure that we're providing quality care. So of anything that we should be making sure is done properly and above board, it's ending somebody's life on request.
Is there time for one more quick question? Yes, okay, so to Baroness Finley, do medications used in palliative care alter a person's capacity to consent to something like MAID?
They can do, and we have to be really aware that morphine can make you distressed, steroids can make you more emotionally labile. When somebody says that they feel their life isn't worth living, you need to answer that with a question as to why, what's going on, what's happening. And it may be that there is some medication there that's altering their capacity. It may be the cancer itself that's altering their capacity, or the other disease they have. They may have a depression. You have to explore it and diagnose the underlying cause. And then when you've done that, you need to deal with the underlying causes of their distress. But if you just respond at face value, then you'll never begin to understand the person and what they really need. And the dangers are forgetting that autonomy is relational. We all interact. The way the doctor behaves towards the patient alters the way the patient perceives their outcome. There's good evidence from Canada that dignity is enhanced by the way that care is given, or it's undermined by the way that it isn't given.
Thank you.
Thank you. With that, we are now officially at the end of the panel, and I would like to again thank our witnesses. I think we all agree here your views were made very clear this evening in this second panel. We very much appreciate you taking the time to be with us. And with that, I will officially adjourn this committee.